rheumatic diseases is an umbrella term that encompasses the spectrum of musculoskeletal, arthritic, and connective tissue disorders with onset in childhood. These diseases can affect a child's eyes, joints, skin, muscles, and gastrointestinal tract. Although these autoimmune and inflammatory conditions share some common symptoms such as pain, heat, and swelling, each also has specific symptoms. Rheumatic diseases can affect children of any age and any ethnic background. The cause of rheumatic disease is still unknown, and in many cases, the cause may vary depending on the type of disease. There is currently no cure, but many children will go into remission or have infrequent symptoms. Stay tuned as we discuss pediatric rheumatic diseases. It's another day with the physicians, where your health is our business and will always be our business. My name is Dr. Martina Agbere, the regular anchor on this program, and with me in the studio is my co-anchor.
My name is Dr. Memuna Iskabri. Welcome to the Physicians, where your health is our business.
Yes, we'll be discussing pediatric rheumatic diseases. When you hear the word rheumatic, what actually comes to your mind?
It's not even about what comes to mind. What is I'm excited about today's topic is the fact that we've been talking about adult, arthritis and the various types, and we know that it's not about aging, but we have children that can also have these diseases. And now we are having a life.
Don't even go there. Don't even go there. Don't even go there. My own excitement is that what you think you see most in adults, you're also going to see them in children. And not only seeing them in children, you have an expert
who knows
actually knows so much about this disease condition.
That's nice. Please hurry up and bring her in. Hurry.
You can say that again. We'll be back after this short break. Please stay tuned. Call one person, call two persons, pick up your phone and tell them that the physicians were here live. Thank you.
Every day and in every way, enjoy that I find support. No matter the role you play, you dream back supplement for you and me. In your body, that I fight you.
Darvite Nutritional Supplement is loaded with essential multivitamins, minerals, and natural ingredients that helps you to be at your best. Darvite from LB Pharma. Darvite, love yourself.
Welcome back. If you have just joined us, you're on to your regular health TV talk show, The Physicians, where your health is our business. Today we'll be discussing pediatric rheumatic diseases. And in the studio with me is a consultant rheumatologist. Pediatric rheumatologist is actually the first pediatric rheumatologist in Nigeria. So we've always told you that we always bring the best to you on The Physicians. We'll try to walk the talk. And she is a consultant, like I have said, with the Lagos State University Teaching Hospital, Dr. AYODELE FALEYE. You're welcome to our program.
Thank you so much.
I just
Thank
love
you.
Yes, I've been admiring your complexion, really black and beautiful and intelligent.
Thank you
Before
so
we
much.
continue, how does it feel being the first
pediatric
rheumatologist in Nigeria? That's number one. And how many do you have now?
Okay. Thank you so much.
Female.
Thanks
right?
for
Yes.
Okay. Thank you so much for the warm introduction. It feels cool to be with you. And yes, how many do we have in the country? That is what you meant by your question. Okay. As at now, I know of only myself. We are 2 in West Africa. And
2 in West Africa?
Yes. And in the whole of Africa, we have less than 20 pediatric rheumatologists, and not all are practicing pediatric rheumatology.
And Dr. Me, she's also been in the museum,
yes,
right?
Yes. We are taking her away after this now. We put her then, we'll be collecting.
We have to put in the museum because we need to come and look at you and see, and just ensure that you are not going to jackpot.
No, to ensure that she's not AI.
Yes.
She's not AI, yes.
Yes. It's actually nice meeting you one-on-one.
Same here.
Okay,
I'm happy
it's a
to meet
privilege.
you. Thank
So
you.
let's go straight to our topic. Let's hear it. But I'm sure you are full of stuff. You want to just keep saying these things. And
No problem.
what are pediatric rheumatic diseases?
Yeah. Thank you for that question. Let me go through that through each word. Pediatric. That means an individual less than 18 years. When you say rheumatic diseases, you are referring to disease of the joints. And probably, you are referring to also musculoskeletal system as a whole. Now, let me now put it straight, that when you say pediatric rheumatic diseases, you are talking about chronic immune-mediated musculoskeletal diseases, which occurs in individuals less than 18 years. I will still break it down. When you say chronic, that means it is lifelong. That means that the patient lives with it all through their lives. And when you say immune-mediated, that means you are trying to say that it is autoimmune. That means auto means self, immune means the body soldiers, our protectors. And that is why most of us are not sick every day. We come across germs, we come across dirty things, but we are not sick because we have immunity. But sometimes, instead of the immune system to protect us, they go word. And they start fighting the body itself. The body they are supposed to protect, they start fighting. They can fight the brain, they can fight the eye. The one can go blind. They can fight the kidneys. Kidney failure sets in need for renal transplant. And that is what I meant by immune-mediated, lifelong, autoimmune disease, which affects the musculoskeletal system. When you say musculoskeletal system, you are referring to the joints. You are referring to like the knees, the ankles. You are referring to the muscles. You are referring to the bones. These are the major sites, where one can have symptoms when you have a pediatric rheumatic disease. And there is a particular symptom that cuts across, and that is arthritis. Okay. What do I mean by arthritis? That means a joint that is swollen, painful, red, and with loss of function. For example, let's take the wrist, because I'm treating children. Children write a lot in school. So when you say a child has arthritis, let's imagine that the wrist is affected. That means that child cannot write. The wrist is swollen, is painful, is red. The function that it's supposed to do, it cannot do. So, and let me correct this notion. A lot of people think that whenever you have joint pain, that is arthritis. No. Yeah. Joint pain is not the same. Yeah. Yes, it's not the same as arthritis. It must be swollen. If it is not swollen, it is not arthritis. Maybe I will say that is arthralgia. A painful joint is arthralgia. A swollen, painful, red, with loss of function joint is what we call arthritis. So there's a difference. And that is what we look out for. So we have musculoskeletal physicians for children. We look out for chronic diseases of the musculoskeletal system in children. Now, let me also put this through, that you see, not all the diseases that we manage are actually autoimmune. Some are benign diseases, like we have what we call growing pains. We have children with chronic musculoskeletal pain. Maybe they have flat foot, plantar fasciitis, and all the likes. We see these ones too in our clinic. But the major one of great concern are the autoimmune-mediated one, because of the its high burden, high fatality rate, and likely any child affected will not have a very good health-related quality of life.
And so that takes us to the next question.
Yes.
What is the statistics? Because you said lifelong chronic. What is the statistics, and how common are they in Nigeria?
Now, we do not have data.
Wow.
Yes.
We don't usually have data. Do we have data? Wow.
Let me.
That's why she's there now to help us build up this data.
Yes, but I can share with you my own experience in Lagos.
Okay,
exactly. Maybe when you know about my journey, you will understand what is going on. Yeah. These diseases are termed to be rare. Okay. Even in the medical school, we were not taught. Right. We thought it was a disease that affects, they are diseases that affect Caucasians and not blacks. That was what we were told. There's this funny picture in most textbooks. You just see butterfly rice. Lupus. That's all we knew. That's all we knew in the medical school. But it's beyond that. It's beyond that. So when you now talk about all these diseases, we do not have data, but it's been documented in the US that it affects 6 to 7 million children per year.
Per year.
Per year.
6 to 7 million per year. That's
Yes.
So maybe we are underdiagnosing and misdiagnosing.
Yes, I feel that in Nigeria there's underdiagnosis, under-recognition in this environment.
Now, need a high index of suspicion for you can do that.
Yes. There is a study from my own center before I started pediatric rheumatology. That was from the AYODELE unit, where they documented, I think, 56 cases of pediatric rheumatic diseases seen over a period of 5 years. But now that we created our own clinic in February 2022 in LASUTH, officially the pediatric rheumatology clinic was established.
Awesome.
If I look at the data that we have got, we have more than 100 cases.
Just within 2 years?
Just within 2 years. My first year as a pediatric rheumatology training with the AYODELE unit, we had just 25 cases. After then, I went for international training, but I came back in 2022, and between 2022 and now, we have 100 cases.
So there'll be a lot of underdiagnosis.
Yes, and the
diagnosis too.
Yes, the issue why we are having under-recognition and under-diagnosis is this. These diseases do mimic the tropical pediatric diseases. Okay. It's possible you meet a patient with pediatric rheumatic disease and you feel it's malaria. You may feel it is tuberculosis because the patient may just present with cough and weight loss only, and you are looking, you feel this is tuberculosis, you run all the tests and you feel that at the end of the day, every investigation you are supposed to do to exclude tuberculosis, they were all negative. But despite that, some still go ahead to treat TB presumptively, and that makes diagnosis to be delayed. Patient is with the pulmonologist or with the respiratory unit for 1 year taking TB drugs, whereas it is not, probably likely a rheumatic disease. So it's possible that we mistake all these diseases for sickle cell anemia. It's possible because we now have some children with sickle cell anemia who are living with rheumatic diseases now. It is due to knowledge, improved knowledge that has made us to realize that not all vaso-occlusive crisis in sickle cell is vaso-occlusive crisis. It may be a patient with juvenile idiopathic arthritis. Then not all patients with hyperhemolytic crisis in sickle cell that gets transfused all the time. We had a patient at a point whereby the patient came in with history of being transfused 13 times within 6 months. A sickle cell patient, yes, 13 pints of blood within 6 months. So I was just discussing in the department that day, and the unit felt, oh, let us give her a consult. Maybe it is any of the diseases that she's looking out for. So we screened the girl, and it was actually a juvenile systemic lupus erythematosus coexisting with sickle cell anemia.
After 16 pints of blood.
Yes.
That is very disheartening. So what is the difference between this pediatric rheumatic disease, the arthritis you find here, and the one you find in adults, number one? And will also tell us the causes of pediatric rheumatic diseases.
Thank you so much. Thank you. Let me start by saying this, that we know most times when we mention arthritis, what comes to mind is disease of the old women.
Yes.
That the old woman that uses a stick because she cannot walk straight again. That's what comes to mind. But I'm here to tell us that arthritis is real in children. That we have tiny warriors suffering from arthritis. And how is it different from that of the old women? Arthritis in old women is as a result of aging. And that is what it's as a result of it's of mechanical cause. When they move around, when they walk around, that's when they have the pain. And why do they have this pain? A joint is where two bones meet. And at that point, there's a cushion that we call the cartilage. So that those two bones, it will reduce friction between them when we move around. But as we are aging, this cartilage, they get old. And when they break down, bone starts to touch bone, and that's what causes the pain in them, and they're unable to walk well. That reduction of friction is gone as a result of aging. And I've told us that it's as they move around that happens. Now, the arthritis in children usually is autoimmune mediated. Okay. What happens is this. It is worse in the morning. Why am I saying that? when a child wakes up and the child with arthritis wakes up in the morning, they are unable to jump out of bed. It will take 30 minutes to 1 hour to be able to jump out of bed and start to walk. And as they walk during the day, they get better. Not like the old woman's own that, you know, it's when they wake up in the morning, they have relaxed, but as they walk around, they have the pain. But this one is, you know, autoimmune. They wake up in the morning, 30 minutes to 1 hour. Even if they are able to get out of, they are limping. After some time, they start to walk well. So in the night, they sleep again. They wake up tomorrow morning again, they start, you know, they are stiff. Yes, that is the word. They are stiff, they are unable to walk well in the morning. So it's quite different from what we call mechanical one. Or let me use this term. This one I've just described is what we call inflammatory arthritis. That of the old woman will say it is non-inflammatory or mechanical. But the inflammatory one, early morning stiffness with pain, which resolves as the day goes by, is what characterizes it.
And so we are now saying what are the different causes?
Yes.
Of this?
Yes, the causes of all these pediatric rheumatic diseases is unknown, but it could be familiar. We've had a case of a mom with polymyositis, but the daughter was later diagnosed with juvenile systemic lupus erythematosus. So it runs in some family. That means there could be genetic predisposition to it. Now also we can look at environmental factors, like maybe, you know, viral infection in a child that is genetically predisposed. Not just anyone. Anybody could have viral infection, we get over it. But in a genetically predisposed individual who is coming across a particular infection, after the infection is over, then they can now develop any of these diseases. Like when there was COVID, we had issues.
In fact, that's what I was going to say.
Yes.
What's the intersection between COVID-19 and rheumatism?
Yes. During the COVID year, I wasn't in Nigeria. I was in South Africa. Okay. And you know, COVID was of in South Africa then. And what happened was this: we had up to 50 children who came down with what we call pediatric inflammatory multisystemic syndrome, which we call PIMS, or in some climes they call it MISC, multisystemic inflammatory syndrome in children. So we saw quite a lot of cases. You know, children will have had COVID, they will not have symptoms. 6 weeks after, they will come down with high-grade fever, a characteristic rash, they look red, erythematous lips, they look red, their lips is dry, cracking. We had those that were convulsing. We had those with abdominal pain, yes, who were misdiagnosed as appendicitis, and they had they went in for appendectomy, but no, the appendix was not inflamed. They were actually brought back to the ward. It was after then we screened them for PIMS, and we actually noticed that it was post-COVID. And even when I came back to Nigeria, I met a particular boy who had something that is similar to Kawasaki. That time, 8-year-old boy, he had Kawasaki disease during that COVID year. And when I came back 8 months after, I diagnosed him with juvenile idiopathic arthritis. He's still in clinic. So that was the cause. During COVID, he had Kawasaki. From Kawasaki, we are now on GIA.
For our audience, what's Kawasaki?
Yes.
Yes, it is one of the diseases we manage. It is a medium vessel vasculitis. Usually we see it in young children, especially boys below the age of 4. 4 is the maximum, but COVID proved that wrong because we had grown-up children now coming with these features. They do have high-grade fever. They will have arthritis, swollen joints. They will have a red eye, conjunctivitis. They will have red lips that is dry and cracking. Then they are very irritable and sick children. Yeah. They are being co-managed with the cardiologist because their hearts could be affected. They could have what we call coronary aneurysm. Their cardiac vessels become dilated and could rupture, and we could lose them. So it's a dear emergency, you know, which we co-manage with the cardiologist.
Okay, so you've talked so much about all this, and I'm sure my audience is just watching and waiting. We also heard about a lot of misdiagnosis. So obviously, you will need a high index of suspicion. Not every doctor is difficult for doctors to be able to see these children and say, okay, this is what the child actually has. Not talk of people at home. Yes. So how is the diagnosis made, and how is it managed?
Yes.
Is it curable?
Yeah. Thank you so much for your question. How do we make diagnosis? Diagnosis requires high index of suspicion, especially in this environment, because we have malaria with us. And sometimes people go around, they will be treating them for typhoid, sepsis, they don't even know what is wrong with the individual. We have what we call classification criteria for most of the diseases. You know, for juvenile idiopathic arthritis, that is a child who is less than 16 years, presenting with arthritis of at least 6 weeks duration, less than 16 years, arthritis of at least 6 weeks duration, after which you must have excluded all common causes of arthritis. That means you have excluded infection like hepatitis B, hepatitis C, septic arthritis. You are so sure that no, all this, even TB, yes, could be a cause of arthritis. So you have excluded everything, and you now feel that, oh no, all these common things have been, is a diagnosis of exclusion. So that is the criteria. If you have a child less than that for 6 weeks, if it is less than 6 weeks, we hold on. Usually we can observe the child. You wait for the disease course. You wait, you know, sometimes it may take some time before you now make up your mind what you are actually managing. For juvenile systemic lupus erythematosus, we have a classification criteria whereby we look out for the most popular malar rash. But one thing is this: the malar rash is not so common. In literature, not everybody has it. Yes, you are right. Not everybody has it. We've seen cases of juvenile systemic lupus erythematosus before that presented only with recurrent convulsions of 9 months. Finish. And 14-year-old girl. And she was with the neurologist all through.
Yeah, because it could be Kleeflander syndrome.
Yeah.
That's what they
thought. So usually they tried monotherapy, did not work. They couldn't control seizures. Dual therapy, no, they could not. They increased the dose of the medications to the peak. They could not control the seizures. But after that, she developed arthritis of one of the joints, and that raised index of suspicion, and that was how she got a diagnosis with us. We actually screened her, and it was a case of juvenile systemic lupus erythematosus. So diagnosis, we follow classification criteria, but in this environment, that may not be so straightforward because we live with a tropical disease. So each disease has its own
treatment?
The treatment, we have what we call disease-modifying anti-rheumatic drugs, which we call DMARDs, disease-modifying anti-rheumatic drugs, and we also have what we call steroids. We make use of steroids, we make use of disease-modifying anti-rheumatic drugs, and other supportive medications for these children. Then also, I think you asked me a question about the after treatment.
Is it curable? And to add to that, as we round up, to add to that, what's the role of family support, caregivers?
All right.
Because this is, you said, it's a chronic lifelong.
Yes. These diseases, most of them are not curable. But juvenile idiopathic arthritis has 7 types. We can't cover this today. If I take each disease entity, we can't finish today.
We need a separate session.
There are some types of juvenile idiopathic arthritis. The child may outgrow it. Okay. There are some. If they do not come with the pain for 2 years, they are on medications. You can discontinue the medications and you observe them. You don't discharge them completely from clinic. So there are some of them, but for the connective tissue disorders like juvenile systemic lupus erythematosus, juvenile dermatomyositis, juvenile scleroderma, vasculitis, they need to transition to the adult clinic. Okay. So we have a standard adult clinic now where they transition
to that age. They move to
once they are 18, they move to the adult clinic.
So finally, Dr. AYODELE Faleye, finally, what are the challenges encountered in management of this patient in Lagos, Nigeria?
Thank you so much. The challenges are real, to be honest. It's easy to clerk a patient, take a detailed history, examine the patient. When it comes to the point of making a diagnosis, it's difficult. Most cannot pay for the investigations. The investigations we do in rheumatology are quite expensive. What we call them autoantibodies. Yes. It takes, most of these blood samples that we take are not even analyzed in Nigeria. It takes 10 to 14 days before we can have the results. And they are very expensive. With the foreign exchange crisis, they are super expensive now. Wow. In fact, this year, I don't think I have done more than 2. Most of them cannot afford it. So it's difficult to, that's a challenge because we cannot even run investigations. Then when it comes to the points of treatment, when you give a prescription sheet, they cannot afford the medications too. Because
even if they are available.
Even if they are available. And one thing is that some are not even available. In Nigeria, they are in abroad. And those that are even available here are with some pharmaceutical companies, and they are very expensive. That is a big challenge to us. We keep losing patients. Default rate is high in the clinic. They come in, they get a diagnosis, they don't come back. They try to go for herbal medications, and that is a problem.
It's very challenging. Interesting topic, but ending it on this note with all these challenges that we have is very, very disheartening. And we just hope and pray that our government and other stakeholders will come on board to support this. If you have an NGO, you should be able to make it known so that people can actually try to support as much as possible. Thank you so much for coming on our program, and we look forward to seeing you again. It is obvious we have a whole lot to discuss, and so we can enlighten the public. Really appreciate your presence.
Thank you so much.
And to our viewers out there, I just want to say thank you for keeping the day with us today. You have heard all that she said. The only thing I want to appeal is let us support. Let us render our hands. It's not only government. Government can't do it alone. There's a lot of things that government actually they're into. But for these ones, stakeholders should please come on board. Let's support this particular disease condition so that we'll have a fair and better society. My name remains Dr. Martina and Remy. Till next time, stay blessed.
Thank you so much. The beautiful, brainy Dr. FALEYE. This is so amazing and eye-opening. We talk about medical conditions. We say it's interesting, but of course we know that people that are going through that will not see it as interesting.
Yes.
To our viewers out there, thank you so much for always keeping the date with us. And you've heard everything about pediatric rheumatic diseases. It's not as common as it is, but it's life debilitating and chronic. So please, any index of suspicion you think you or somebody, a child has it, please, you now know there's one human being, one Dr. FALEYE at Lagos State University Teaching Hospital. And be kind, please to follow us on all our various social media platforms. Until next time, my name remains Dr. Nimina Isokari.
Every day and in every way, enjoy that I find support. No matter the role you play, nutrient pack supplement for you and me. In your body, that I fight you.
Darvite Nutritional Supplement is loaded with essential multivitamins, minerals, and natural ingredients that helps you to be at your best. Darvite from LB Pharma. Darvite. Love yourself.